I would like to introduce our Dean, Dean Ira Colby. He is the Dean of the Graduate College of Social Work. Thank you, Dean Colby.
Good morning, everyone. Oh, geez. I know it's Friday, end of the semester. Good morning, everyone. Thank you, thank you, thank you. It's good to see you all, and I'm really excited to be here. And Patrick asked that I do a little bit of an overview about this conference, how we got to here today, about social work and research in social work, and then introduce our plenary speaker, Dr. Lovell Jones. The genesis for this program, it just didn't spring forth from the head of Zeus. This has been really coming on and growing gradually in the college. And it really started with our doctoral program under the incredible leadership of Dr. Maxine Epstein, when we started our doctoral research spring symposium. And we had the Doctoral Student Journal, which was the only one of its kind in the country, and that really was all due to Maxine. And the research conference for the doctoral students was very, very exciting, and we had that in the spring. And then in the fall, when we created the new curriculum, when the faculty came up with this new idea about a research conference poster session, we did that for Patrick for 2 years, I believe, 3 years, 2 or 3 years. And then in conversations with Maxine, the idea came up, why don't we merge this together and have a day-and-a-half GCSW research conference where all our students are coming together, sharing their research, sharing their ideas. And so what we have today is a growth and an evolution over time, and I do want to give all props to Maxine for her leadership in making this happen. Maxine, thank you very, very much. Now, research is critical to us in practice. Research helps us discover new ways of practice, figure out how we can do interventions and come up with plans that will strengthen our communities, help strengthen families and individuals' lives so they can succeed. If we didn't have research, we'd only be going by our gut. Our gut tells us this is what we should say, this is what we should do. And the gut doesn't work all the time. That's why we need research. That's why we need scientific inquiry, which is what you do as social workers. That's the core of our work. It's called critical thinking. And so research, however, just didn't start in the 20th century. Social workers, if we trace our history, the very first conference that we had as social workers was in 1874. It was called the National Conference on Charities and Corrections. I loved how they linked charities with corrections. They were sort of sending a message that if you needed help, you probably were similar to a criminal. And that's always been an underlying theme in human services. And if you go back and you read those early proceedings, and they are in the library, by the way, and I would encourage you to go to the library and go look up the proceedings from the National Conference on Charities and Corrections and read the early volumes from the 1870s, 1880s, and 1890s. And what you're going to discover, there are people just like you who are asking critical questions. And this was from, and I just pulled one out yesterday just to see what did they talk about in 1886. And this says on their piece, kindergartens. Should we have free kindergartens for children? Now think about that. Kindergartens, by the way, that's not required in Texas. And they were talking about this in the 1880s. Should we have free kindergarten for children? The reform school problem. What do we do with young people? Moral evaluation in reformatories. What is required to produce it? Labor in prisons. If you're listening to the Republican debates right now, you hear one of the candidates talking about children should be working in schools as, first he said as janitors, now he said as librarians, dealing with child labor laws. And back in the 1880s, they were talking about child labor laws. Should we have these? What do we do with children in the state? Boarding out of dependent children. Organization of charities. Trampery. What's trampery? Homeless people. These are the issues that we discuss and we go on. What are the causes of pauperism and crime? Hospitals for the sick. Immigration and migration. Major discussion item in the 1880s. So what we're dealing with today was dealt with by our cousins and our aunts and uncles over 100 years ago. And we are still searching for answers to these perplexing, complex issues, and that's what research is about. The university has a major, major responsibility for our society. Here at the University of Houston, we believe that the thing that drives us is student success. And student success takes place through the university, through its historic traditions. One is the preparation of people for competent ethical practice in a progressive workforce. Two is inquiry, asking questions, searching for new truths, because what we know is not what we will need to know for tomorrow. So we're constantly asking questions. And then the third, and for me, probably the most important function of the university, is to make sure that our previous truths are housed, collected, and made available to people, and that we transmit that information to all people. That's the role of a university. And you are actualizing and realizing that role today. In the College of Social Work, we do our research in any number of ways. Historically, we would go off on our own and do our individual research, but now we organize our research around centers. In most research universities that you visit, you will find the common denominator are centers. And there's a center for this, a center for that, an institute for this, an institute for that. And it brings together faculty, students, community people together to form partnerships to try to find answers to these perplexing questions. In the Graduate College of Social Work, we currently have the Center for Drugs and Social Policy Research. We have the Children and Family Adolescent Center, which is what I call it, but that's not its official title. It's called Families. Patrick, what's the name of? Family Center for Innovative Research. I just called it Children, Families, and Adolescents. My bottom line is, name me an issue that doesn't come back and tie to the family. Every social issue somehow impacts the family. We also have the Virtual Reality Resource Laboratory. We have new initiatives underway, the GIS initiative and the evidence-based initiative. These are all things that the faculty coalesce around to answer questions to strengthen our practice. But what I'm really excited to be able to announce officially today, after 2 years of discussions with the University of Texas MD Anderson Hospital, we now have signed an official formal agreement signed by all bodies that now creates the Center for Health Equity and Evaluation Research, which is a joint partnership between MD Anderson and the Graduate College of Social Work and the University of Houston. And this new center, which will be dealing with health gaps and health disparities, is now located in the College of Social Work. And this is a very significant historic occasion for the university and for the city of Houston. And why we're really fortunate, and you're going to hear more about health disparities in social work because this is becoming a very significant issue for us nationally. But what we're fortunate to have is a leading expert who is going to lead this center. We have an individual who is known nationally and internationally for his work around health disparities research, and that's Dr. Lovell Jones. And Lovell is a research professor in the College of Social Work. He has an appointment with, he has so many appointments. If I was going to read his CV, I would be here for the next hour and a half. I mean, he's the director of this, the director of that, research professor of this, research professor of that, and I can't pronounce half the things he does. They've got all these ologies on the end of them. But the one thing is that Lovell is known for his passion and commitment around health equity research. And he and his staff we're now going to be starting the renovations in the college on the 3rd floor. You've probably seen all the disruption up there. Now we're going to go ahead and build that out over the next few weeks. And then come January, the staff for cheer will be in the college. And at that point, we will have another hopefully significant announcement to make about the center and its work. But this will become a leading force, not only for this college and university, but for the United States as we try to grapple with health equity, not health disparities, health equity, which is a very different way of looking at this issue. So I'm real pleased and honored to introduce and bring and ask to come to present to us this morning a wonderful, wonderful scholar, thinker, leader, good friend to the college, and now somebody who will be joining us in faculty meetings, Dr. Lovell Jones.
Thank you, Ira, for that warm introduction. I want to thank the organizers, especially Peter. Patrick. Not Peter? What I will tell you, as I was saying to Ira, I was asking him what day it was today, because I've been on the road a lot. In fact, this is my one-day visit to Houston before I leave on Sunday for a week. I'll be back for, excuse me, for I think 2 days the following week, and then I'm gone the rest of the time, 2 weeks. But I couldn't miss, actually, when extended this invitation by Patrick to give this keynote address. And I will try to give it within my allotted time, because as I tell people, when I'm put in front of a mic, I turn into a Baptist preacher. And so I go on and on and on and on. What I'll try to do in the 30-odd minutes that I've been allotted is to try and give you a quick overview of why we are where we are and why there's a need for a change in terms of the paradigm with regards to addressing health disparities. That even though we've spent millions and millions and millions of dollars in different efforts over the last 2 decades to address health disparities in this country is getting worse and not better. And that's its Achilles heel to a large extent. But I'm an educator by profession. What most students don't realize is that, and faculty to an extent, is that your degree, your PhD, or your degree is a degree in philosophy. That's what it is. That's the historical basis of a PhD. It's added in terms of your area of emphasis, but it really is a degree in philosophy. And I'm probably one of those last, and hopefully not final, Renaissance scientists to an extent. My mentor was a Renaissance scientist, his mentor was a Renaissance scientist. And that is to try and look at the issue in a broad sense and not in a very narrow box. But what I'd like you to do is, over the next few minutes and days and weeks and months, is to think about these questions. And think about them now, and then think about them after I give my presentation and where you fit in the scenario. First of all, who suffers from health disparities, and has the efforts on health disparities resulted in a reduction in health disparities? Secondly, and I've already given you the answer to that one. Okay. Secondly, what additional data do you believe should be evaluated, and are additional questions that should be raised in order to help determine the most effective courses of action to addressing the problem of health disparities? Third, how much do you think health disparities cost this nation, and should the term used be health equity and not health disparities? Going from a negative to a positive. Is that part of the reason, is that we tend to frame this in a negative way as opposed to framing it in a positive way? And then fourth, what were your perceived views prior to this lecture? After the presentation, what are they in terms of the causes of health disparities? Were you surprised by your perceptions? Why or why not? And then lastly, take some time to outline 2 to 4 approaches you think you can do to address this issue, and form teams to implement them in your communities. This is not your neighbor's problem. This is not a politician's problem. This is not our or my problem. This is our problem in terms of addressing this issue. And let me give you quickly, I always like to give lessons learned up front for those who kind of doze off, because our mind span in terms of attention is about 20 minutes. And so I try to give enough information in the first 20 minutes, knowing that I will start losing people as it goes past 20 minutes, because that's your attention span to a large extent. Unless I start dancing and singing and keep you awake in that manner. But first, no one center or one institution or profession will solve the problems we face. We tend to stay in silos, and I think that's part of the issue. Secondly, if you always do what you've always done, you always get what you already got. 3, what is publishable may not be relevant, but what is relevant can always be made publishable. Think about this in terms of, while I'm standing here, there's probably have been 10 to 20 to 30 papers submitted somewhere online within this city. And what's their relevance? Other than getting someone promoted and dotting an I or crossing a T and that sort of thing. A true change in the paradigm is needed. True change, not change, but true change. That's the key phrase. A person's perception is a person's reality, whether real or not. If you perceive you can't get care, no matter what I tell you, that's your reality. And I can tell you all day that you have access to this, that, and the other, but if your perception is you can't do it, I better address your perception first, because I'll never get to the reality of the issue unless I do that. If the problems are in the community must be involved in determining the solutions. We tend to put our grants together and then approach the community. Excuse the phrase, but that's ass backwards. We need to involve them up front in any discussions that take place, because generally what you end up designing may not fit them. And the example I'll give you is something that took place in this city not too long ago, several years ago actually, where a group went out and did what's called a windshield survey with regards to where a clinic should be placed. They did the survey, they got the information, they built the clinic, and on the opening day of the clinic was prenatal care. And the opening day of the clinic, most of the people in the audience were over the age of 50. What they had seen were grandparents taking care of their grandkids without understanding the culture, the area, and what was going on. If you attempt to address the disparity issue as a single problem of just one disease without taking into account other factors, you've already failed to address the problem at the beginning. And you've already, it's like placing a Band-Aid on a heart attack. It may make you feel good, but what about the patient to an extent? And then lastly, the solution to the problem revolves around these 6 key words: trust, respect, partnership, communication, flexibility, and knowledge. And I can give you a lecture on all 6 of these in terms of their relevance, but I don't have the time. To move forward, we have to look at the world as it is becoming rather than how it has been. We have to see how we have to stretch ourselves to become related to this ever-changing scenery. We have to gain a recognition not only that no one stands alone, but on a positive side, that we also need each other. In the long run, it is how we relate to each other and how well we work together that will make the deciding difference. This is a translation from a phrase that she actually, Dr. Hyde, actually wrote and gave to President Franklin Roosevelt. And if you go and visit in St. Louis, the arch, and at the bottom of the arch, you'll see a paraphrase of this statement, which is as true then as it is today. We need each other. Whether you're a conservative Republican or a liberal Democrat, whether you're an atheist or a Christian or whatever, it is the unity in terms of our working towards a purpose that will solve our problems. Health is probably the best indicator of the failure of this nation to address the issue of skin color and our social class on the future well-being of this nation. It is. And until we get to that point and address this openly, and to show you how resistant we are in terms of discussing this, one of the key elements that really crippled President Clinton's presidency was his first presidential executive order. Few people do not remember that. It was to address the issue of race and racism in this country. And he held a major event outside of DC in which he brought every aspect of the community together. And he was so roundly criticized for addressing an issue that people said, it's over. we don't need to be talking about this, that he dropped the whole thing. He never brought it up again in his administration. A golden opportunity that was lost. An unhealthy city, an unhealthy county or parish. I was born in Louisiana, so I have to put parish in there. An unhealthy state and an unhealthy nation are not and will be economically viable. Unless we address the issue of health, we can talk about jobs, we can talk about the issue of increasing jobs, but if you don't have a healthy society, it won't matter. In 1966, King once said, of all the forms of inequality, injustice in health is the most shocking and inhumane. It is still that today. It is still that today. Have we changed? Have we really changed? Have we really changed our outlook on things? Think about this recent headline in Memphis in terms of the merger of Memphis and county school districts. The headline says, it revives race and class challenges. And what was the most interesting thing about this was the guy who was involved in that issue in 1970 is the same guy involved in the issue today and made the same statement. He said, there are the elements of fear. It was a physical and personal fear. Today, the fear is about the academic decline of the Shelby schools. What's different in that statement? Is there any difference? The words are different, but is the fear different? Is the perception different? Remember, perception is the reality of the person who perceives it. I put this up. What's the change? I don't see a change other than the words in terms of access to care. We should have had a major human outcry when this came about, when this was put up. The American Medical Journal, the Journal of the American Medical Association, in 2008, published this as the lead article and an editorial that said, despite all the money that we've put into health disparities, we've made no change. And made a statement that this was the Achilles heel of this nation. What has changed since then? Nothing, really. Here are what I say as the four problems, and they're more than this, but I kind of put them in this group. Health is not a national priority. Disparities in health in America, are they real? Race as a biological construct is a blessing and a curse. And what about the word race, racism, racialism not being resolved? Anybody know what the word racialism is? It's been around since 1968. Dan Moynihan actually coined the phrase. And it is the idea of stereotyping and profiling that has very little to do with what your skin color is. For instance, in Appalachia, if an Appalachian comes down into Louisville for care, what he will do, or what she will do in most cases, will find a city relative to go with them. Because if they come down and they open their mouth, they're already stereotyped and profiled by their dialect, have no money, and generally will sit in that clinic until the last patient is seen to be seen. That's racialism. That's stereotyping and profiling to an extent. When was this written? Can anybody tell me when this was written? One thing, of course, we must expect to find, and that is much higher death rates at the present among blacks than among whites. I wrote this, submitted it for publication, and it's one of the few articles that I've ever, this is the abstract from it, one of the few articles that I've ever had accepted without any revisions. The reviewer said, insightful, brilliant. I mean, these were the words used. I had to withdraw it because I plagiarized it. This is the person who wrote it. And he wrote it over 100 years ago. All I did was change the word Negro to black in the city from Philadelphia to Houston. Those are the only changes I made. So how far have we come? Look at infant mortality. A nation that is not concerned about the most vulnerable of our populations, how can they be concerned about you and I? The black-white ratio in terms of infant mortality has not changed in 100 years. Listen to this, the black-white ratio in infant mortality has not changed in 100 years. In fact, in the last 6 years, it's gone up. Think about that. Think about that. And I could fill this room, this building, this campus with publications on infant mortality and all the things about infant mortality and this, that, and the other. But what difference has it made? I mean, it's brought the absolute number down, yes. But the ratio is increasing. Relevance versus publications. Think about that. Try not to become a man of success, but rather to become a man of value. It is the issue of value and how we value each other. We can't solve problems by using the same kind of thinking we used when we created them. And I took these and I said, how can we expect solutions from those who benefit from the problem? It is in their vested interest to continue the situation when they are unaware, and sometimes aware, what the impact will have. They live for the moment and not for the future. That happens in academia as well as in corporate America. Einstein said, insanity is continuing to do the things the same way and expecting a different outcome. We're insane. We're insane because we have not challenged the system to do things differently. And if you wonder where this phrase came from, if you always do what you've always done, you always get what you already got, from Miles Mabley. I'm of that age where, you know, the mop and the TV and the jokes and that sort of thing. Unfortunately, when we approach efforts to deal with the lack of real progress in addressing health disparities, we tend to fall back to what we've done before. It may be under a different name or packaged in a different box, but ultimately it is the same strategy. Healthy People 2000. Healthy People 2010. Healthy People 2020. What's changed? I thought we had learned when I was involved in putting together Healthy People 2020, because we had made a conscious decision, and I made the comment, you know, people are going to expect that you put a number behind it, and then all of a sudden they're going to lose interest in doing something when you don't reach that, and you continue not to reach that. So why don't we say Healthy People USA? Well, we didn't learn. Healthy People 2020. And are we moving towards that? I'll let you be the guest. Unlike the statement on this monument, I find that I tend to honor everyone, but I tend to insult everyone. Because we have allowed this to happen. We have allowed this to happen. Us. When we talk about our elected officials, it is us who elected them. It is us who elected them. And then we complain. Or we sit home and don't vote. No, I don't have anybody to vote for. It is us that is doing that to us. So, is health a major priority? I could give you 2007 figures, but I don't want to depress you any more than I'm already depressed. I mean, we spend more on cosmetics than basic education. And these are the same trends. The numbers have changed, but the trends are the same. We spend more on ice cream than we spend on clean water. We spend more on pet food than we spend on reproductive health. Pet food. You know, pet food. And I won't tell you about the military. I mean, that number is just astronomical. So is health a major issue? Is it a priority? I would say not. And what does it cost us? I mean, when this report came out, we should have been in the streets. Health disparities health disparities over a decade will cost this nation $3.7 trillion. $3.7 trillion. How much does health reform cost? About $1 trillion. How much are we asking to reduce the deficit? About $1.2 trillion. Well, I got an answer. I've been on the Hill saying, I got an answer. All we need to do is reduce health disparities by 1/3 over the next decade. By 1/3 over the next decade, we will save this nation $1.27 trillion. Solution: no cuts. No cuts. Solution: no extra money. Solution. But are we doing that? No. So again, is health a major issue? Is it a priority? Disparities in health, are they real? Yeah, well, I mean, the last Gallup poll, 62% of white America said health disparities was not a priority. That it was a social issue that was being created by other groups. But there have been reports. And who are the uninsured of this country? Who should be concerned? Not who we think about. It is individuals between 19 and 39. That's the uninsured. It's not the guy under the bridge that you see trying to wash your windows when you stop. They have children. Their household incomes are between $20,000 and $60,000 a year. Would anybody have said that? They're white, and they work in small businesses. What was your perception? It wasn't this. What do you think the perception of America is? It's not this. It is that illegal immigrant, we're pitted against things that really we shouldn't be pitted against. And race, is it, biological? How do we define race in America? How do we explain it in terms of health disparities? I put this up. It hasn't changed. I've been saying this now for a decade or more. They haven't changed the text. Maybe one day they will change it. But number 4 is the greatest one I like, to show you the idiocracy of this. A vague, unscientific term for a group of genetically related people who share certain physical characteristics. What's wrong with that sentence? This was in a $400 medical text. What's wrong with that sentence? How can you be genetic and unscientific? I'm waiting for somebody to explain that. You can be genetic, but unscientific in the same sentence. These are all taken from medical texts. How many of you know about the 1-drop rule? 1 drop, you're black. I got a solution for a racial problem. All I need to go into Africa and find the darkest person and get a syringe and come back, and every white person I see, I give them 1 drop. Powerful drop, right? Must be, You define the whole race by 1 drop. I tell my friends that if you live in Georgia and you're Asian, you're black. It's on the books. It's still there. It defines an Asian. If you want to know why if you don't know history and why history plays a major role in addressing health and health disparities, ask yourself the question, why did most Chinese move from Mississippi to Texas when they first came here? Because in Mississippi, they were black. In Texas, they were white. Think about that. So you move across the state line, you change your racial classifications. I guess the biology must change, Position of the sun, I don't know, something. Virginia's the same way. When we think about this in terms of African Americans, and I want to phrase it for a part of this in that, when we think about slavery in this country, we think that most of the Africans that came out of Africa came to America. Didn't. Only 5%. 95% went to the Caribbean and South America. 95%. But there was a very select group that came to this country. And they all spoke different languages. They had different cultures, different religions. And so out of that, I say to my scientific and geneticist friends, God must have laid hands on them somewhere in the middle pastures to make them all genetically alike. Because that's how we group them in terms of studies. And so we don't ask the question about why this publication says, well, African Americans show this trait, and then another publication comes around and says, no, they show this genetic trait, and then another one comes around and says, no, they show this genetic trait. Yeah, they do, because they're different. They're not the same. It's not to say that disease prevalence are not the same, and that doesn't have an, but it's the populations, not genetic, in terms of grouping. Okay? To give you an idea that it crosses races in its populations, we talk about the hypertensive belt in the South. Well, think about this and look at historically. Georgia, South Carolina were prison states. Okay, they were prison colonies. There were no women for 75 years. No white women. Okay? Men are not celibate for 75 years. And so when you hear people talk about, my original family came over on whatever ship and landed in Georgia, and I've been here since the first group. Oh, okay. So you're white? Let's think about that one. Strom Thurmond was black, he just didn't know it. Or he probably did, but he didn't want to. The one-drop rule came out of South Carolina because the majority of the population at one time in South Carolina was mixed. And there was a need to try and keep the land and property into white America. And that's how the one-drop rule came about, because they were able to define people in that way and property values in that way. So think about that. The same thing in terms of breast cancer. When they talk about breast cancer in terms of Maryland, most people don't realize that in terms of the trade that came over, Irish, Scots, white females that came over, the majority of them that came over were indigent servants. They were slaves. They were maintained in slave quarters. They were maintained right next to Africans. And so about 30+% of them had relationships with African males. And so I say to, which one of these guys is black and which one is white? It's a good question. I'll let you think about that one. All of these are black women. But if you look at this woman over here and she came into your office for counseling or whatever, what would you say? She's Asian, right? Her dad is black. Okay? So by the one-drop rule, she's black, okay? Would she be eligible for Bideal? The FDA-sanctioned drug for black America? Don't know. All these guys are Asian. Okay? If you go by the one-drop rule, each had one parent that was Asian. Okay? Well, here's my friend. There are a lot of drops. 16% West African. He was born in Maryland, so he was white. He was born in Louisiana, he would be black. Because someone would know his lineage and where his parents came from. The reason why he's that way is that he's Scotch-Irish. And so if you trace his lineage back, you'll find that one of his parents was an indigent servant, a white Scotch-Irish female who had a relationship with an African. Okay? So think about that. And then racism, racialism, are they not resolved? In our society, we see value and behave towards one another through the powerful lens of race. Race is perhaps the single most defining issue in American society. Perception versus reality. What if I were to tell you that both of these individuals came out of the same store less than an hour apart? One was looting and the other one was finding. What if I were to tell you that both of these were college students? The one is the bottom, one is the top. When I asked the reporters about why they said this, they immediately said, I'm not a racist. I said, but how did you classify one as being looting and the one being, well, I said, no, both of them are college students. All three of them are college. Oh, well, I didn't know that. You didn't ask. You made an assumption, and therefore you defined that person as looting. Unconscious in terms of going forward. And I put this up. You know, this often happens to me to a large extent. You know, I wonder how he feels about O.J. I wonder how he feels about Farrakhan. I wonder how he feels about affirmative action. You know, the existence of health disparities is not just a scientific and medical issue, but a moral and an ethical one. So what are the solutions? The solution to health disparities require no new laws, but a willingness on our part to change the way we address the problem. It will take no dramatic increase in new money, but a change in the way in which we allocate the money we have. The solution to the problem will also require the willingness and commitment to take the first real steps towards the solution, real steps. If the problems are in the community, then the solutions are in the community as well. The idea of health in minority communities and underserved communities cannot be approached as a single issue. It has to be done in a holistic manner. You just can't go and talk about cancer without talking about cardiovascular disease, talking about homelessness, talking about joblessness, all of the issues that impact that community. The words I mentioned before, it is, in my estimation, we need to take a biopsychosocial approach to this and expand it. George Engel was the first to talking about this and almost got run out of his profession. In fact, it was nurses that picked this up. Physicians kind of threw this to the side and stopped looking at it, and it's been nurses that has kind of kept this alive. We have kind of integrated and changed Engel's statement to reflect a more multidisciplinary approach, and some people talk as if it's a transdisciplinary approach to addressing this issue. It is taking biology, the molecular biology of the subject, the psychology of the subject, and the sociology of the subject to take a holistic approach. It is to frame a research vision that's inclusive and that has a contextual framework that integrates molecular and cell biology, behavioral biology, as well as social sciences. It acknowledges all possible influences that might affect health and the quality of life, both positive and negative. It is understanding that health cannot be addressed as a single issue, that it has to take into account other factors that influence the perceived need for health care and attentions to health concern, housing, education, economics, a whole list of things. CDC wants and has this on its webpage, and has had this on its webpage for the last 15 years. But I have yet to see anyone talk about it in any publication other than what I've talked about. And that is the idea of syndemics, a set of linked health problems involving two or more afflictions interacting synergistically and contributing to the excess burden of disease in a population. Syndemics occur when health-related problems cluster by person, place, or time. Health disparities is a classic example of this. See how this integrates? And when I talk about the way we do clinical trials is absurd. Not that we shouldn't be involved in clinical trials, but we're looking for the healthiest person possible to do a clinical trial. You can't have this, you can't have that, you can't have this, you can't have that, you can't have this. And we wonder why stage 4, stage 3, stage 2 diseases are still a problem. Because we don't address the real problem in terms of how this interacts syndemically. It's going to take a multidisciplinary approach. And if I have a few more minutes, okay, let me run through an example. This is a study I proposed about a decade ago. Could not get NCI funding, could not get NIH funding, could not get any funding. Actually applied to ACS 4 times. The first 3 times I got outstanding scores. but they told me I needed to focus on one specific, I need to do the biology, or I need to do the psychology, or I need to do the social, not all three together, or write 3 different grants. And I was stupid enough, I applied the 4th time, and they triaged it. They gave me a worse score. I mean, it was a non-fundable score. And so what I did was I packaged it and I sent it to every board member of the ACS. And I said, here's the identical grants. Here they are. How can I go from 3 outstanding scores to a non-relevant score? If it's outstanding, it's outstanding. Well, what happened was I also sent it to ACS Texas Division, and they said they would give me 1 year to prove my point. Well, I guess it must have thrown fear into ACS National, because they called me up and said, we'll give you 4 years. I said, fine, I'll take the 4 years. I had asked for 5, but 4. It was the idea that researchers too often look at community-based research as something placed in the community as opposed to research truly placed in the community. And what we did was, we went out, and there's a hole-in-the-wall restaurant that's not too far from University of Houston that every major politician, black, Hispanic, will go and eat at when they're running for election. You know where the place is? It's right up. Huh? No, not the Breakfast. Breakfast Club is the upper young one. Huh? No? I'll ask you to find out. It's just over here, 1, 2, 3 blocks over. No, it's not Ruby Grill. But you'll see it as we go. What we did was, we approached the owner, and we said, we want to launch this in your cafe, in your restaurant. And then talking to him, we found out he couldn't eat in his restaurant because he was a diabetic. And we went, whoa, wait a minute, okay. I tell you what we're going to do is redesign your menu. We're going to go in there and help you. And he says, but I'm going to lose business. I said, I tell you what we're going to do is, the day we launch this, everyone who comes in, we will pay for that meal. We will give them a free meal to test it. We won't tell them it's a healthy meal. We just tell them it's a change in what you're serving, you know. And so we had a research dietitian go in, do the announcement. And what she did was, she said, here is a food that, we're just trying and getting you samples. Guess what? Today, 10 years later, that menu is still there. And he's eating in his restaurant. And whether we published a paper or not, we have changed that community. We've now published papers off of it, but we've changed that community. That's what real science is about. That's what real science is about. But in doing this, we also made sure that when we went in there, because remember, we were doing a prevention study. And in most prevention studies, you tell somebody you're either eligible or not eligible. And if you're not eligible and you have a comorbidity or some disease, you say, oh, there's a clinic over here, and you go to that clinic, and we're recommending you. What we began to design and what we began to realize is that we needed someone that would become a health referral specialist. And this is one of the programs that we're going to be trying to launch in the Graduate College of Social Work, more formally. And we've actually talked to the National Association of Social Workers to credential that program as well. And so we're moving forward. And what that health referral person does, is she becomes, or he becomes, the control of the 3-ring circus, okay? In that it is a navigation that occurs both in the community, in getting them into care if they need to get into care, but navigating them through care, but realizing they have to go back out into the community again. And you need someone to coordinate that care from beginning to end. And that's what the health referral specialist does. But we also found out that there are programs out there that pay for care. How many of you knew, and you probably know better than I did, but if you have stage 2 cancer, 70% of the time you're eligible for SSI and having your care paid for. If you have stage 3 and 4 cancer, it's 100%. You just have to know how to fill out the paperwork. In most cases, it's not getting the paperwork filled out in the proper way. And so what we've been able to do is find a corporation that does that. That has an 85 to 90% success rate in doing it, and tying that into a research program so that people come in And if they don't qualify for our program, we refer them in for care. Do we have problems recruiting people in our clinical trials? No. Because they know that we care as much about them as we care about our research. And our purpose is to do something to improve their health and their health delivery. The reason why I'm in this is because of this picture. I want this nation to survive. And I don't think, if we don't address health disparities, I don't think it's going to. I truly don't. Every economist, whether they are conservative Republican, ultra-conservative, and I've been in the room with them, or liberal economists, have said if this nation reaches where its gross national product, its GNP, reaches in terms of health care cost 25%, we are automatically a debtor nation and will not survive. Where are we today? 18%. Where were we when I started graduate school? 6%. It has not changed. It's flattened out this past year, but my fear is that it will start going up again. Memorial Hermann healthcare system in this city says that if something isn't done in the next 3 to 5 years, it will be out of business. If something isn't done in the next 3 to 5 years, it will be out of business. Think about that in terms of the health of this city, of having the largest nonprofit healthcare system in the city, the largest in the nation, going out of business. And they said, they don't have to go out of business, they just have to stop people from coming in that can't pay, or can't pay the rack rate. That's 1/3 of this city. Think about that. So if you want to change the world, you got to be that change. You can't sit on the sidelines. You can't say it's somebody else's problem. But you have to remember that in doing one brave thing, you need to run like hell, because this is not the climate right now. But you also have to remember that no matter how hard you work, no matter how hard, no matter how right you are, sometimes the dragon wins. The idea is staying out of the dragon's mouth. And I believe that we have a voice inside us that tells us what's right and wrong. How we listen to that voice and act on it produces the people who are. And we are not listening to that voice. We are truly not listening to that voice. Thank you.
I'd like to thank Patrick Leung for inviting me and working so hard and getting this together. Level for being my mentor, and Ira for bringing me on board to form part of this great faculty. I'm kind of the new kid on the block, and so I feel very welcome. Thank you, Andy, for being my mentor as well. Today I'm going to talk to you about the research that I do internationally. I do a lot of my research with Latinos in the United States, but the other half of my research is my international work. And this is a study I'll be presenting today that was conducted in 2010. We did a survey of Latin American palliative care physicians and on their attitudes and beliefs and practice patterns related to communication at the very end of life. So I'd like to acknowledge my co-authors on this paper, and I'm happy to say that I've included one doctoral student from the Graduate College of Social Work who's a fantastic student, Traber. She wasn't able to make it today, but she's working on writing up the results with me and publishing this paper. But before I get into presenting the results of the study, I'd like to give you a little bit of background on what palliative care is, because even within the health professions, there's a lot of confusion about what palliative care is, what it's not, what's the role, and frankly, it is a new discipline. Palliative medicine is a new discipline, so it's not surprising that even physicians who are not palliative care physicians don't have a good understanding of what we do. And I'm really happy to say, too, that this definition that I'm going to work through with you together The World Health Organization definition of palliative care was authored by Eduardo Bruera, who is the chair, who's my other boss at MD Anderson and also my palliative care mentor. So the WHO defines palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by the means of early identification and assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And palliative care came out of the hospice movement out of the UK in the 1960s. After that, it kind of spread to other parts of Europe, came to the United States and Canada probably in the 80s, and now it's developing in Latin America. And I'm very committed to the development of palliative care in that region of the world. So what is palliative care? Well, it provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. This is important. It intends neither to hasten or postpone death. It integrates the psychological and spiritual aspects of care. It's holistic. It's interdisciplinary. It offers a support system to help patients live as actively as possible until death. And it also offers a support system to help the family cope during the patient's illness and throughout their own bereavement period. We use a team approach. Social workers are integral in our teams in palliative care. Our goal is to enhance a person's dignity and their quality of life. And this can also positively influence the course of illness. So our focus is on quality of life, and we are person-oriented. So we try not to say a cancer patient, we try to say a person with cancer. But you guys might have seen what happened, came out in the New York Times. This was all over the news about a year ago. A big study came out showing that palliative care, in fact, indeed, non-intentionally actually extends life. And this is a very positive finding that we're trying to replicate through other studies. And we believe that this is just kind of, although not the intent of palliative care, this is a result of what happens when you provide quality care, right? So my background is public health. I'm a doctor in public health. So I see palliative care as a public health issue. It affects everyone. It's an area where we know that it can prevent suffering. It has the potential to prevent disease too when we take a family approach. It prevents suffering, it provides peer education, it provides patient-centered care. We incorporate self-management programs. And the World Health Organization also has now, this is kind of like the evolving concept of what palliative care, and I don't have a pointer, but before a person was diagnosed with cancer and they would receive curative treatment, so there was like a vertical line would be drawn instead of this line that's drawn now. So the idea is that palliative care and pain relief should be made available to patients from diagnosis onward, not just limited to the last weeks of life. The old model was, okay, you receive curative care, and then all of a sudden the oncologist turns you over to hospice, and then it's end-of-life care. Now, what we do in our conception of palliative care now is to offer a wide array of services from the point of diagnosis on forward. So it's integrated. There are people who are receiving palliative care, for example, who at the same time might be receiving chemotherapy. And this is something that's not uncommon. Okay. So now that we have kind of an understanding of, so somebody was asking me the other day, so is hospice care palliative care, and how does that, so yes, all hospice care is palliative care, but not all palliative care is hospice care. It just so happens that the work that I do is pretty end-of-life care. It's kind of towards the end. And the study that I will present today addresses some very end-of-life issues, okay? So just a little bit of background on the study. We know that there's been limited research in Latin America regarding the communication between palliative care physicians and their patients related to their diagnosis and prognosis. And we also know that truth-telling practices and preferences and physician perceptions regarding patient disclosure preferences reflect an important ethical dilemma they're associated with the tension between the principles of autonomy and beneficence, which we know can vary across cultures. So cultures that are predominantly Catholic, Latin, Mediterranean, have very, very different notions when it comes to truth-telling. Okay, so last March, from March to May, the Research Commission of the Latin American Association of Palliative Care, that I'm very active with, conducted an anonymous survey of physicians registered at our conference that year that happened to take place in Buenos Aires. In the survey, we wanted to identify the current palliative care physician attitudes, beliefs, and their practice patterns regarding communication with terminally ill cancer patients. And most of the items and scales that we used were drawn from a questionnaire that Bruera and colleagues used 10 years earlier with that same group of physicians in Argentina as well. So the aim of the study, what we wanted to do is we wanted to compare their attitudes and beliefs and their practice patterns across 2 time points regarding this very delicate issue of communication with terminally ill cancer patients. And so compare the findings 2010 to those that we found in the year 2000. It was just a cross-sectional descriptive analytics survey of the physicians who were registered at this conference in both years. And the survey instrument included items on physician characteristics, truth-telling preferences and behaviors, DNR orders, patient disclosure preferences, their practice patterns, their training experience, and some questions on decision-making. And in 2010, we decided to add some items that are also very controversial on physician-assisted suicide and euthanasia. And we'll go through those terms a little bit. The analysis was quite simple. We conducted bivariate analysis using chi-squares. And let me go over, we got 200. It's a pretty good sample. Again, palliative medicine is new in this region. And most of the respondents were from Argentina, followed by Brazil, Colombia, Uruguay, and Chile. And then we had some representation throughout the rest of the Americas. Most of the respondents were female. Most were under age 45. Most identified as Catholic. And most identified that religion was either very important or pretty important in their lives. Most dedicate most of their practice to palliative care. Let's see, over 50% had less than 10 years of experience in palliative care. And most of the physicians dedicated a good portion of their practice to oncology patients. In terms of their background specialty, most were general internal medicine, followed by anesthesiology and pain doctors. We had a nice spread in terms of their primary practice setting. We can see that most of them practiced in a hospital-based palliative care unit. And we also had a good number, 21%, who practiced in home health care, which is also something new that's developing in Latin America at this point. And we had a nice public-private distribution as well. Okay, so these are the comparisons in terms of their attitudes, beliefs, and their practice patterns regarding truth-telling. Most physicians, in fact, over 92%, in both 2010 and 2000, believed cancer patients should be informed of their diagnosis. However, the proportion of physicians reporting that at least 60% of their patients knew of their diagnosis increased significantly from 52% in 2000 to 75% in 2010. Physician support for patient knowledge regarding the terminal stage of their illness also increased over this time period, as did the proportion of physicians reporting that over 60% of their patients actually knew of the terminal stage of their illness. So we're seeing this change here, just in one decade. Interestingly, this is very interesting, in both years, in 2010, we asked the physicians, if I had cancer, I would want to know, and lo and behold, almost 100% of them, they would want to know of their diagnosis. Okay. So then we asked them questions about their perceptions regarding patient and family preferences regarding whether they want the information disclosed or not, information related to diagnosis and prognosis. And we found that almost a twofold increase in the proportion of physicians indicating that at least 60% of their patients and families wanted to know the terminal stage of the illness. And these perceptions are really important to capture, because physician perceptions of how they perceive, physician perceptions of the wishes of patients and families can, of course, influence their practice and maybe account for some changes that we're seeing in terms of their actual behavior. Okay, and then these are the items that we added, the controversial items. I think we like controversy a little bit. Palliative sedation, physician-assisted suicide, and euthanasia. And a lot of people get these terms confused, so I decided to just kind of talk about each of the terms. Palliative sedation is when we use sedating medication, okay, to decrease a patient's level of consciousness, to mitigate intractable suffering, but not to hasten the end of life. So the intent of palliative sedation is to relieve intractable suffering caused by refractory symptoms that will not go away after trying everything else, and not to deliberately end life. So that's palliative sedation. Now, physician-assisted suicide is, the goal is to alleviate suffering of a terminally ill patient by providing them with medication that the patient can then take to hasten their own death. So hastening death is a primary and intended outcome. This is a legal distinction, and it's also an ethical one, okay? Euthanasia, of course, is the administration of medication by health professionals, and the intent there is to shorten in the life of the patient. So we're clear on the differences between. So when we ask them questions related to their attitudes and beliefs regarding palliative sedation, we found that most of the physicians agreed that palliative sedation was indeed appropriate for symptom management and existential distress at the end of life. And then when we asked them about their practice patterns, we found out that 64% of the physicians who responded are in fact using palliative sedation in 40% or less of their patients. So they're using it. And then when we asked them about their attitudes and beliefs regarding physician-assisted suicide, we can see that the physicians are split kind of like right down the middle regarding physician-assisted suicide, but it appears that the vast majority of palliative care physicians don't support euthanasia, okay, 80%. And then we asked them about decision-making and how they like to make decisions and how decisions should be made. And at both time points, the majority of physicians agreed that shared decision-making would be most appropriate in their workplace. Yet at both time points, they also reported that physicians are still making the decisions in their workplace. Although we did see a trend, it wasn't statistically significant, towards increased shared decision-making. And then we asked them to rank the bioethical principles of justice, beneficence, and autonomy. And in 2000, physicians ranked justice over beneficence, which was ranked and rated over autonomy. But look at this shift in 2010. Autonomy was ranked higher than beneficence, which was rated higher than justice. Unbelievable. These findings are just now, identical to what we see in Canada and the United States. So the Latin Americans and the South Americans have become North Americanized, it appears, in terms of their bioethical principles. So in conclusion, and we can talk about that, our findings suggest that there has been a significant shift towards enhanced disclosure and communication preferences and practices regarding cancer diagnosis and prognosis in Latin America over the past 10 years. In fact, a big shift. This change, we believe, of inclusiveness and disclosure may reflect the growth of palliative care education in the region. A few caveats. The sample was small in 2000. It was quite small because the movement was small. Our organization was small, but we felt it was representative of both times. And of course, this is a preliminary study. We need more research to validate these findings, as well as research to assess patient and family disclosure preferences. Of course, these aren't generalizable to other regions of the world and to non-palliative care physicians. And one thing, I presented this study a couple of times over the summer, once in Lisbon, Portugal, and once in Athens. And bioethics is a big area of research and scholarly activity in Europe. And I just kept on hearing, and reading all about this intercept between culture and ethics and the tension that exists between the principles of autonomy and beneficence and those from, the Anglo countries versus the Mediterranean countries. It was a lot of debate and very, very interesting. And in fact, over the summer, I was writing a grant, a bioethics grant, focusing on identifying preferences related to truth-telling in older Latino populations. And I was working with a colleague of mine who's a bioethicist, a North American bioethicist, and we kind of got into debates. I mean, that's what you do in bioethics. You debate this stuff. You deliberate a lot. And he was telling me, well, Isa, if we find that older Latinos don't want to be told the truth, I cannot tell people to lie. I said, no, we're not telling people to lie, first of all. But we had this big debate. So one of the things I told him, I said, the right to know and to disclosure does not necessarily mean that we shouldn't be tailoring the content and the timing and the manner of communicating the information to specific individuals or cultural preferences. One of the big things about quality care, one of the biggest measures is patient-centered care. And in order to do that, we need to respect patient preferences. So, and then I told him, isn't it like if we don't respect patient and family preferences, aren't you being just as paternalistic and limiting autonomy in other cultural contexts? So we can go, we need a balanced approach. We need a balanced approach. But that's some food for thought. And with that, I'm happy to take any questions.